Welcome to Healthcare IT Today. I'm John Lynn, together with my colleague and friend Colin Hung. The world of technology and healthcare are ever changing in new and novel ways, and that's why we love this stuff. So join us as we discuss the latest healthcare and health IT news, meshed together in new ways which help generate ideas and new perspectives. Plus, we'll have a little fun along the way. Today, we'll be doing a health IT regulatory roundup with some of the biggest headlines coming in the world of regulations. And be sure to follow the show on social media at the hashtag HITSM and our personal accounts at TechGuy and at Colin_Hung. Plus, check out our 17 years of health IT blog content at healthcareittoday.com. Did you ever think you'd be a policy geek when you grew up, Colin, or is that...
Absolutely not. And even worse, I
And you're
never
still
thought I
not.
would actually, well, that, but also, I never thought I would actually get excited over it. Like, it's one thing to cover it and talk about it, but I'm actually excited about some of these regulations and some of the changes that are coming through. So it's pretty crazy.
Well, I think the crazy part is that, this came out and a bunch of them came out and it wasn't even Friday. So they weren't even trying to hide it because it actually was a good news. So I think that's, yeah, but it's interesting. I mean, they've been working in DC on a lot of interesting regulations. So I think this is going to be a really exciting episode.
Yes, well, more for you than for me. I mean, you've always been the policy geek, but yes, let's dive right into some of these very, very interesting headlines. The first being, of course, John, it just came out that HEFCA will now include Fire in 2024. So there's provisions now to say that the Fire APIs are going to be there. What
Yeah.
are your
So
thoughts on that?
yeah, ONC came out and said that the Common Agreement version 2.0, which by the way 1.1 was just released, that they're actively working on the Common Agreement version 2.0 with a publication goal of no later than the end of spring 2024. So that's actually pretty fast for regulation. But they said their plan is that this version will include participation with HL7's Fire transactions. So within 2024, QHINs and Tefka could include Fire. Well, it's interesting because one of the biggest complaints I heard about QHINs was that it didn't include Fire. Many people, not the least of which was Don Rucker, former ONC national coordinator, among many others, said this feels like a step backwards for us to do QHINs and do CCDAs. And, why are we doing that? We should be moving forward towards Fire. So I guess this is ONC's response to that is, yeah, we're going to, and they accelerated that, which, credit to Don for being a proponent of that. And I think that always was the vision. Of course, the devil's in the details. What does that mean? What is Fiery ready for it? Which I think is why it wasn't included initially. So I'm interested to see how that plays out. But, overall, I know a lot of the startup companies, for example, at Health that we were at, when you talk to them, a lot of them talk about Fire and using Fire and, being Fire enabled and all those types of things. So in that regard, I think it's a good thing.
Yeah, I mean, I think you're absolutely right. The devil will be in the details. This is encouraging, right? I mean, we've heard it from quite a number of the people that we talked to at the various conferences. They're like, all of us were scratching our heads going, why not Fire, right? Why not go there? Um, you know, we don't know the exact timing and what parts of Fire, right? Because you're right, there are parts of Fire that maybe aren't ready or aren't accepted. That's why maybe they went with CDA at the start. But I think overall, this one was one of those announcements where I think it was sort of a non-announcement. It's like, oh yeah, we were all kind of expecting this, maybe a little bit sooner now,
Yeah.
with all the pressure that was coming. But I think we all figured it was going to come sooner or later.
Yeah, I think that's the bigger announcement is how quickly they're incorporating it. So, I think that's where we'll see some interesting change. I was talking with Mario Highland, interop guy on Twitter that we know, and he's actually announcing a connectathon that they're doing that's actually interestingly focused on the practical use of Fire, which HL7's done lots of connectathons. Other ones have done connectathons, but many of those are saying, "What's next? What's the next version of Fire?" And so he's addressing a different opportunity, which is, okay, what about the standards we actually can use today? as a developer, and can we do a connectathon around those standards? It'll be interesting to see how that plays with this incorporation with QHINs and how that plays out. But it was interesting that he saw this problem that, hey, well, in the standards community, we always want the next standard, right? And we want to expand the next one. We'll see how that plays within the the interoperability community. Is that something that's needed? Because it makes sense if you're a vendor, health IT vendor that says, okay, I want to go to learn about fire and how I can incorporate it. And you go to a connectathon by HL7 or whoever that's saying, what's the next standard rather than what can I do today? That is a bit of a disconnect. So, obviously that plays out into the question of, can fire be implemented? Is it ready? And I think, connectathons like that are really interesting to do that. And, if it's going to be incorporated in the QHINs, it's going to have some sort of maturity or it won't really fly.
Do you think any of the QHINs are going to struggle with this? Or do you think they were kind of like, hey, we knew it was coming. We're ready for it.
Yeah, I think it was Health Gorilla that I was talking to, and don't quote me, I guess, but I think it was them. They were like, "Well, on our back end, we're already using Fire. So whether we're using Fire on the other end, he said we're using Fire. So I think a lot of them already have some sort of Fire capability built in for So I don't really see it as a problem. They're doing a lot of Fire stuff for whatever other service they were doing besides the QHIN. So I don't think that will be a problem. Maybe there's some edge cases that will be challenging for him, but actually, I've talked to some of the QHINs that even just something like high trust was a challenge for him because they hadn't done it, and that's quite a heavy lift to go and be high trust certified. So, yeah, there's a lot of nuance there, but yeah, I don't think fire will be a problem for most QHINs.
All right. Well, let's move from fire to talking about something a little more interesting, a little unexpected, actually, I thought. But that is the new regulation or the new policy guidance around telehealth doctors do not have to give their home address as their practice location anymore.
Let's start with the idea that they were going to have doctors do that. Like, how absurd is that, right? Especially when you look at our fourth topic for today, right? It's about the Facebook pixel tracking and privacy and all this. And they're like, wait, who had the idea that like we need to have the doctor's home address because the doctor just happens to be doing the telehealth visit from home? Like, the obvious concern by doctors is, especially with the way many doctors are being treated. We've seen especially in the ER, a lot of mistreatment of doctors and aggression. I think we even had a shooting, if I remember right, of someone in the hospital, right? And so like, wait, why would I want to give out my home address for someone to do this? So, credit to ATA and ATA Action, some of the American Telehealth Association, Telemedicine Association, for pushing this forward and saying that's ridiculous. The interesting part is that they only have it right now until the end of 2024. So we may have to revisit it again unless some other policy comes up between now and then. But yeah, but at least for now, the Medicare providers that are doing telehealth, telemedicine, they don't have to publicly report their home address as their practice location, which seems like common sense, doesn't it?
Yeah, this is also falls in the category of we all figured this was coming, but we just didn't know when. But yeah, I think the bigger story was the way it had been worded, which was around, hey, like you have to disclose your home address. So the follow-on implication of some of that, or at least I heard some of the docs at MGMA and a few others talking about people were going to literally stop doing it, right? Because if given the choice of disclosing their home address or providing telehealth, unfortunately, they said we're not going to do it. There's too much risk of providing my home address that they simply were not going to offer that service anymore, and so they didn't have to disclose, which is kind of sort of so counter to the whole improving of access, which is what this was meant to do. Anyway, it's one of those ones where yes, finally someone woke up and said this is ridiculous. Let's use some common sense here, and you don't have to use your home address. You can use your practice.
Isn't that the annoying part of telehealth, though? There's so many things that seem like common sense that they haven't done. For example, the fact that a doctor has to be, certified as a doctor, accredited as a doctor in every state by the state boards. Like we need medical licensure to be national because it just makes sense, right? Like again, but again, it makes sense, but it's not the reality today, and we know why. We've talked about this before. But there's a bunch of things like even reimbursement for it, other things like that. And so this was just another example of where people don't understand telehealth. It's still kind of, the annoying stepsister or stepdaughter. I don't know. It's a problem.
Yeah, it's definitely a problem. Although I think, the other ones you mentioned around licensure and so forth, there's dollars with that. And whenever you bring in dollars, it takes a lot longer to make a change, right, to the status quo. With this one, at least there were no dollars associated with it. And so it
Yeah.
was just a quick little, well, not a quick little, but like a change that could be made, and it didn't really affect anybody's pocketbooks, right? And it would, and, we've already seen a decline in telehealth. In terms of usage, I mean, people, have shown that they want to come back to the office, and docs prefer to have people come back to the office. We've seen the cuts to the reimbursement, in terms of how much they get reimbursed for telehealth, and that's just led to maybe a right sizing is the right word of the amount of telehealth that's available and the amount of telehealth that's actually done.
Yeah.
So to cut it further arbitrarily with these kinds of rules would have been a bit of a blow to not only that industry but to people who rely on that form of access.
Yeah, I saw an interesting discussion from I think it was Lyle Berkowitz from KeyCare, if I remember right. He was starting the discussion. Obviously, they have it built into Epic where they do telehealth in Epic. They bought an instance of Epic, and then they use Epic's sharing of the record, so they get access to the record within Epic and can share that with the hospital health system that they're working with. Interesting model, obviously, and he's certainly biased to somewhat that model. But he asked a very important question, which is, who would you like to see you? Your doctor, a doctor who has access to your records but knows how to do telehealth, or a random doctor that doesn't have access to your record that's doing telehealth, or go into the emergency room. There's some other options, I think, but it is interesting. Is telehealth becoming so unique that the doctor's skills, that of someone who's doing all telehealth is actually more effective than, say, your own doctor who does it in between appointments or does it at the end of the day or whatever? It's an interesting question to think about because there are nuances to doing telehealth effectively. Obviously he's biased in that view, I think, because that's his product, but it is a good question to ask.
It'll be interesting to see who's going to come up with the first study, right? Like the purpose, a 100% telehealth doc versus the one who does it part time. Is there any difference in outcomes or effect or perceived effectiveness by the patients? It'll be interesting. I'm sure someone's working on that.
For sure.
Hey, if you're just tuning in, you're listening to Healthcare IT Today with John Lynn and Colin Hung. Today, we're doing a roundup of the hottest regulatory news, which is a word I never thought I would say together. Today's episode is being brought to you by the Sway Health Live 2024 conference. It's the annual gathering of healthcare marketers from all parts of the healthcare ecosystem, including provider-based marketers as well as health IT marketers. It's happening May 6th to 9th, 2024 in Atlanta. We just made the big announcement. And you can go to Sway Health, that's Sway with two A's, .health/live for more information. Are you looking forward to that conference, John?
Yeah, well, I'm excited to go back to Atlanta. Atlanta's a definitely underrated city for fun, for good restaurants, for easy access, of course, that everyone knows. But yeah, and of course, I love bringing the community together. We, at the W Hotel has its own branding, which fits perfect for marketers. So it's going to be a great experience.
That'll be a lot of fun. I haven't been back to Atlanta in a long time, so looking forward to that. And yes, I hear the food scene in Atlanta has gotten a lot better, so I'm looking forward to that.
Yep, always about the food, right?
Yeah, it's all about the food. It's all about the food. All right, so let's move into a couple of regulatory areas that now are getting a little more juicy. The first is the, I guess, confirmation or of the disincentives or penalties for information blocking. Sort of
Yeah.
related to the other one we talked about off the top, but yeah, they announced those.
Yeah, and it is just a proposed rule. So, but I think it's going to go quickly because from what I hear, because there aren't the same financial issues as some other regulations, it can be processed pretty quickly. But possibly by the end of the year, I think I read something. But anyway, don't quote me on that. I'm a policy geek info, but it did announce three interesting things. The quick summary is that if you are an information blocker, one, there's going to be a wall of shame for information blockers, similar to the HIPAA, security breach, privacy, which I'm sure ONC loves that we call it the wall of shame. But hey, it's stuck. So there will be a list of everyone that's information blocking. So that's the first problem. The other disincentives that they announced was that if you're part of the Medicare Promoting Interoperability Program, then you're going to have penalties there, or they don't like to call it penalties, they call it disincentives. So you're going to be impacted in that promoter interoperability program, also the MIPS one. And then also if you're doing the shared savings program, which is the ACO program, then you're going to not be allowed to participate for an entire year. So that's the easy one to understand. The shared savings, you just can't be part of the shared savings program for a year if you're an information blocker. When it comes to promoting interoperability, they said that the proposed rule could result in a median disincentive amount of $394,353. Of course, that's the median depending on how many practices you have, how many doctors there are, et cetera. But that's significant penalty. And then in the MIPS side of things, their estimates are that if it's an individual disincentive amount, could be a loss of $686 for an eligible clinician. So not nearly as much, but for an estimated median group of 6 clinicians, it's a loss of 4,116. And of course, they said the range is from 1,372 to 165,326 for groups from 1 to 241 physicians. So if you have quite a number of physicians, that number starts to add up and becomes a significant amount. And you combine the two, promoting interoperability and MIPS. And if you're part of an ACO, that's a pretty significant financial disincentive, to use their word, I'd say penalty, for information blocking. So I don't think anyone wants to be on that list. I guess that's the take, that they said penalties were coming, that financial incentives were coming to not information block, and here they are.
Yeah, and just to clarify, yes, HHS is requesting public comment by January 2nd of 2024. So there's an opportunity to comment on these disincentives. So you can head on over to their website and do that. Yeah, I was actually surprised at the strength of the teeth they put in this, because these penalties are quite significant. The one that stood out to me was the one you just mentioned, the ACO, where if you're found to be an information blocker, you cannot participate in that program for up to a year. That's significant. So on one hand, I'm encouraged. I actually like this because now it'll force people to abandon what has been a very, very questionable practice for a long time, like to block the access that patients have to their own health information. I do sympathize with folks who maybe haven't implemented any technology to help them with this, but at the same time, I don't think these penalties are too strong. I think they're actually about right. Like, I wanted them to be significant enough where someone is just going to be like, oh yeah, you know what? Let's just finally get around to fixing my ROI process. Let's finally get around to doing this because boy, yeah, let's avoid these penalties.
Yeah, I see this as ONZ said, we want to use every lever possible to have people not information block, because they shouldn't. And they
Right.
shouldn't have an excuse to information block, right? The other question I have, which I'm not 100% sure, but I think this is just essentially the ONC CMS penalties. I think OIG could do some other penalties associated with it. So, this might just be the beginning of some of the disincentives to not information block. But, what it tells me is that they're serious about not wanting people to information block, and they don't expect excuses. I do wonder, will this cause some people to say, well, let's not participate in the promoting interoperability. Let's not do MIPS anymore. Let's not do ACOs because we don't want to deal with this. So, that is a risk that they're taking by using the penalties this way, the disincentives this way. but I don't know, that's an interesting thing. We saw this in the meaningful use where many people said, fine, I'll just stop taking Medicare. That's fine with me. And there were some that did. They left Medicare and said they weren't going to take it anymore because they didn't want the penalties associated with meaningful use. So, will that happen with this program? I don't know. It'd be interesting to see.
Yeah, it's funny. It's interesting you mentioned the OIG. That was mentioned in the press release that HHS did. But the OIG civil penalties are separate and could be up as high as $1 million per violation.
Yeah.
If someone is found to be information blocking, again, like the one entity that I'm very interested in, because I haven't heard of anybody, but it's the health IT developers of certified health IT. Um, I haven't heard of anyone on the health IT side who's an active information blocker, but boy, at $1 million per penalty or per violation, I think a lot of them are going to be reviewing their access and their access to data processes.
Yeah. For sure. I mean, we knew stuff like this was coming, and so anyone that didn't think information blocking was going to be a challenge for them and something they needed to address, is certainly woken up now. But now there's the irony, right? So we talk about them wanting to share information and not block information. Well, the other big news that came out, which ironically is kind of more a Sway Health story from for our Sway.health community, but HHS is now being sued by the AHA and some other parties in order for them to use tracking technologies. There were a lot of FTC fines and violations of people who were using things like the Facebook Pixel. Google had some tracking as well. And these hospitals were essentially fined and found in violation for using that because it was sharing the patient's health information. And so now AHA has sued them and said, no, that was an overreach of what you should be doing, and this isn't what the law states.
Yeah, that the whole Pixel thing has been capturing the marketing side of the house since last year, and it's a big problem, right? Like it's huge. On one hand, and by the way, I just had a discussion with our friend Matt Fisher on this, right? He's a lawyer, and actually coming out soon will be our interview where I talked to him specifically about this Pixel issue. But just to paraphrase what he said, HHS originally came out with this rule because actually some hospitals were already subject to some class action lawsuits because somebody had figured out that, hey, there are some hospitals out there that were using these Google Pixels and Facebook Pixels to track patients in order to send them retargeted ads and some other things, right? Uh, and so they sued these hospitals and say, hey, that's a potential violation of HIPAA. And there were enough of these that happened that HHS had to step in and had to define what it meant. And what they were trying to do was define it so that it protected the hospitals. But of course, what they unfortunately did was way overstepped and said you basically any use of these is bad and is actually a violation of HIPAA. And now this is what the AHA and a lot of other hospital associations are taking exception to. And that's because, well, if I just watch a video about diabetes on your website and you happen to use a tracking pixel, and then later on when I go to like some other website and you show me an ad for like your diabetes management or dietary program, but you still don't know who I am, that should not constitute a violation of HIPAA, right? Like, but right now the way the guidance is written, that is, and I think that's what the hospitals are complaining about because a lot of their technologies that they've implemented and a lot of the good things they're trying to do with geolocations and other things to narrow down the search for your doctor by basically knowing where you are geographically. Now they're saying we have to rip all that stuff out. That's crazy. Like that's going to be really bad for patients.
Yeah.
So I think they're suing in order for the HHS to change their minds.
It's fair, right? Because I might be looking at diabetes and it might be about my kid or my mom or my, like and you don't even know who I am. So it's such a good point. Although my favorite part of the highlight of the lawsuit that I saw was that HHS is using this tracking pixel in some of their organizations. So there's a bit of a you can't do it, but we are, and so there's an irony there, and that will be interesting to see how that. I don't know if that has legal grounds. Are they covered the same way by HIPAA or not? So maybe that's not applicable because of the way the regulation's done. But there is an irony that HHS is using the tracking pixel in some of theirs, according to the lawsuit, and so it's like, oh, you can't use it, but we are going to. So that's the irony of government. Huh?
It is, and I think there will be more and more people joining the lawsuit, and I think HHS will change, based on, I'll call it the evidence. Like, it's very clear in one case, it's non-identifiable. If you're just a visitor to someone's website, they don't know who you are, unless you've self-identified. And I think that's where the rule may be modified to, is that if they do know who you are, maybe because you've logged into their portal and they put a cookie on there and now they know who you are, then in that case, you cannot send that information off to Google or to Facebook or these third-party statistics providers or analytics companies. But I think the other problem that was really a problem, and certainly something that Matt Fisher spoke about, is if you're using this pixel, though, on your portal, that is a whole different story, because there someone is logged in and you know who they are. And so what he's saying is that one is a lot more clear, where you should definitely not be doing it there. It's one thing to do it on your public facing website and it's consumable material by anybody. But if you're behind the firewall, if you will, if you've logged in, at that point, he was saying that you'd be, I don't think anybody could argue that that's not a violation. Right? Because now I know who
could
you
you
are.
include that in the terms of service that says, hey, we're going to use a tracking pixel? So then you could say the patient consented to it, right? Potentially.
You could, but the problem is the problem is that it's Facebook and Google are not covered, did not sign a BAA, right? So even though you may have consented, I still would be in violation if I send it to somebody who's not covered by a business associates agreement, right? Yeah. So that's the bigger issue, is that Google and Facebook are not incented to be a BAA, because their pixels are used in a lot of other instances that don't require any of this. Yeah. Right. So yeah, I mean, I hope the HHS will listen and at least modify the guidance. And because now, because of the guidance, there's been a lot more class action lawsuits being filed against healthcare systems that are claiming that people have had their HIPAA, had their privacy violated, when in fact it isn't.
Yeah, it's a bit of a stretch in some cases, right? Is there concern? Yes, should we be thoughtful of it? But the interesting thing is how many patients are suffering because they can't find the treatment that they need because this isn't being used. So how do you find the balance of preserving the privacy but also providing access to the right people to be able to discover the right services?
I mean, I think, and as you just said there's balance, right? There's some really good things about using these tools, especially with, like I said, the geolocating of patients and where they are and narrowing down their search. That's a good thing. You could argue maybe the retargeting of ads is not so great in some cases, but there are some really good use cases for those kinds of tracking pixels. It's not all about advertising, right? It's about geolocations and other things. So hopefully they will come to some sort of understanding to say, okay, like in these cases, makes sense. We should definitely not be using and in these cases, it's okay, because an IP should not be considered personal PHI.
Yep.
Hey, and thanks to all of you who tuned into this episode of Healthcare IT Today. You can find out more details about our show by checking out the programs page on healthcarenowradio.com. And please share your voice and engage with the community at healthcareittoday.com and on social media using the hashtag HITSM. I'm Colin Hung, along with my Health IT collaborator, John Lin. Thanks for listening. Have a great week.